Good morning, good afternoon, or good evening, depending where you are. My name is Juan Correa. This is an international panel about primary palliative care organized by Karo Talks. This is an initiative from the Residence Research Group at La Sabana University. Today, the idea is to dive into the highs and lows of generalized and specialized palliative care in light of the SEEcare UK study results. Sorry. To that aim, we have invited Simon Tavabie, who I'll introduce in a couple of seconds. But first, I would like for you to get to know the panelists that are joining us as co-host of this forum. So first of all, we have Sheila Payne. She's an emeritus professor of the International Observatory of End-of-Life Care at Lancaster University, a world-renowned all-star palliative care researcher. Thank you very much, Sheila, for being here today with us.
You're welcome. I'm looking forward to it.
Awesome. We also have two nurses from the US. First of all, Mary Thelen. She has a PhD at Lancaster. She's a nurse manager and assistant professor at Mayo Clinic. As if this wasn't good enough, she just published this month a ground theory of interdependence between specialist and generalist palliative care teams across healthcare settings. So we're very happy to have you here, and we'll hope to know a little bit more about your study as well. Mary?
Thank you. Thank you very much.
We have the pleasure also to have one of her classmates in the PhD at Lancaster, Rebecca Gagne-Henderson, aka the palliative provocateur. She is also the founder of the Connecticut and a Hospice and Palliative Care organization, which concentrates on approaching palliative care from a community and public health perspective. Rebecca, I hope that we have your intelligent and spicy comments as always, as I already told you. Also from the US, we have Ben Thompson. He's a triple board certified physician, family medicine, hospice palliative medicine, and addictive medicine. He's the director of the Hospice and Palliative Care Fellowship at the University of South Carolina. And he's the division chief of palliative care across 4 hospitals in the Midlands. Thank you very much, Ben, for being here. It's such a pleasure to have you here.
Honored to be with you all.
Finally, from Colombia, we have Marta León. She's the director of the best postgraduate program of palliative care at La Sabana University in Colombia. She's the author of the palliative care strategy, public health palliative care strategy up to 2026, excuse me. And well, hello, Dr. Marta, how are you? Hello. Well, all in all, beyond the titles, the charges, the nationalities, I think that we're just a group of nerdy enthusiasts about public health palliative care who up to talk on a Saturday. And so, well, without further ado, I'll let Simon share with us the insights of his research, after which we'll have a 45-minute Q&A. Simon, please, the floor is all yours.
Well, thank you so much. And I'm so honored to be in such wonderful company on this Saturday morning. So thank you very much. So my name is Simon Tavabie. I'm a palliative medicine doctor working in London in the UK. And like I say, I'm just very privileged to be invited to come and talk to you today about the Seeking Excellence in End-of-Life Care study that we completed and published earlier. Well, we completed it last year, but published it this year. So I thought as a starting point, it would be helpful to just give a bit of local context and a few key points to talk through. Sorry, my slides are not going forward. There we go. Going through for the UK. And so I suppose palliative medicine as a specialty has existed in some form for quite a long time, but more formalized in recent years. We go back and look at the hospice movement in the UK, which had its ties within religion, within sort of missionary work out of Catholic convents. And there were multiple hospices set up across the UK where really good holistic end-of-life care was being modelled. And eventually people started looking at where people were mostly dying, which was hospitals in the UK, and trying to take lessons from the hospice movement into the hospital. We knew that we as a specialty were never going to be able to see everyone who was dying. And so specialists such as John Ellishaw and his team out of Liverpool developed something called the Liverpool Care Pathway back in the late 80s and early 2000s. And that was a pathway that acted as a aide-memoire or a précis of some elements of holistic end-of-life care to try and remind our colleagues who are in the hospitals, those generalists or non-specialists in palliative care, of how they might be able to provide good quality end-of-life care to their patients. Unfortunately, there was some problems with the way it was implemented, and there was a controversy particularly around hydration and nutrition, and actually the Liverpool Care Pathway fell away within this controversy. And since then, we've not really had an agreed way that we support generalists in providing end-of-life care in hospitals in the UK. There have been reports such as More Care, Less Pathway here, and the Leadership Alliance for the Dying Persons report, One Chance to Get It Right, which outlined some of the elements in terms of the priorities of the dying person. But unfortunately, that's not materialized into something a little bit sort of more solid that our colleagues can rely on when they're caring for dying people in hospital. Two more things just to note in context is that the way that we quality assure the end-of-life care of patients received in hospitals in the UK is something that we call NACIL. It's the National Audit of Care at the End of Life. And that's an NHS-wide incentive where hospitals can sign up to review the care of dying people in their hospitals once a year, as it stands. It's going to move to quarterly, but currently once a year. And they do so by case note review. So there'll be a set number. It's normally around 50 patients who've died, that they will review the case notes for evidence of good care. And they'll also conduct surveys of bereaved relatives and of staff to check their experiences of end-of-life care. And lastly, the Health and Care Act, which is an act of Parliament that came into law last year. And it may sound odd, but this was the first the first piece of legislature that ensured all citizens in the UK have the legal right to access palliative care. And that's specialist and generalist palliative care of good quality across settings and without any limitations on time, day of week, time of night, etc. So the reason that I think these bits of context are important is that we now have a legal right to be providing people with this care. We have a legal duty to be providing people with this care, and they have a duty to make sure that we're doing that. The way that we're currently evaluating end-of-life care is through retrospective review of case notes. And we're reviewing the case notes that are made by people who are not specialists in palliative care often. And as we found through the need for things like the care pathways that fell into disrepute earlier on in the context, actually the generalists do need a bit of help. They don't necessarily understand every aspect of holistic end-of-life care in the same way that a specialist might. And the reason that I've put Johari's window up is because actually when we're reviewing somebody else's notes, we're only going to be able to review whether or not the quality of care was good by their standards. And we're actually missing a huge part of the picture, which is their unknown unknowns. So there's a big gap in what we're doing in terms of our practice in the UK. So SEEcare, Seeking Excellence in End-of-Life Care, was our attempt to sort of try and look at a different angle on the problem of caring for dying people in hospitals. So the first pilot study was 4 trusts in the south of England, where we did multiple snapshot audits, where every single ward in the hospital was visited by a specialist in palliative care, and patients who were dying were reviewed against a set pro forma, and a significant unmet need was identified, and 56% of patients who were found needed intervention made by that specialist at that point in time. The Association of Palliative Medicine of Great Britain and Ireland found that shocking and interesting, and convened a working group of people with a variety of backgrounds, from medical, from nursing, from research, from data, from clinical governance, and from administrative sort of streamlining, to try and work out the best way that we could take this model and see how far it could go. We set some objectives, and I think the first objective was, well, we're used to case note reviews as a methodology. Will people accept this sort of prospective, proactive, going out to the wards and finding people and evaluating their care then and there? And we wanted to see whether or not that was acceptable to staff, particularly with workloads always being stretched, and whether it was acceptable to patients and their relatives. They didn't invite the palliative care team in, which is the normal model of referral that we have. Patients have to accept palliative care. And so actually being confronted by a palliative care specialist rather than asked whether or not they'd like to see one could have been an issue. We wanted to see the level of that unmet need that wasn't being picked up in other evaluations. And we wanted to see how much of that need translated in the need to make a change, because it's very possible that all of our patients will have needs every day, but actually some of them have a plan in place that doesn't need altering, and therefore they're receiving good care anyway. As a sort of sub-objective, because obviously we're still early stages at this point, we wanted to see whether or not there were any factors within patient or service design that influenced whether or not there would be higher or lower levels of need, or higher or lower level chances of the specialist needing to intervene. So as I'm sure you've seen from the study, we had registrations from sites. We gave them a 1-week window where they were to pick a day where they were going to visit every ward except for intensive care in the emergency department. And every adult patient who was dying that wasn't known to the team was reviewed against that standardized pro forma. In terms of the pickup, so we had 88 hospitals across the UK. So in all 4 nations, we had representation from hospital sites. On that one day, 284 patients were identified, which I suppose doesn't sound a lot, but for one day, it's reasonable that's a reasonable number. You can see from our demographic information here that the vast majority of our patients were over the age of 75. The vast majority of our patients were white or white other in their ethnicity coding. The vast majority were non-cancer patients, and a large majority of them were on medicine or frailty wards, which one might expect when you think about the kinds of wards where you'd expect people to be sort of okay at providing end-of-life care anyway. We asked, as I said, people to feed back their experiences of doing the work, and the proactive support and the outreach was warmly welcomed by wards. And actually, most teams felt that not only was it helpful in shaping future educational intervention and quality improvement work, but actually it helped build bonds by reaching out to people and asking, let me go and see that patient rather than waiting for a referral. That built those bonds that have then allowed them to develop stronger working relationships. A majority of sites who gave the more in-depth qualitative feedback said that they wanted to include that within their annual audit schedule, so that they would continue to do some element of proactive outreach work and evaluation as a part of their normal audit and service evaluation. There were a few sites, I think it was 7 of the 35, that gave full qualitative feedback that questioned the methodology of identification, in that actually it seemed like quite a lot of work to walk around all of the wards in a big cancer centre to find maybe 1 or 2 patients. And so there probably is a way of streamlining it. But as some of the other sites said, the benefits of going to those wards and speaking to those clinicians actually may outweigh the steps that we count up in doing so. In terms of findings, I think the starkest one is that nearly 93% of, well, over 93% of patients actually, when you did the stats, had demonstrable need of some form. And we always like to think about physical needs, but we try to include elements of holistic care here, because actually that's what we're looking for when we're thinking about end-of-life care in hospital. So around 30% of patients had moderate to severe symptoms. 60% had poor mouth care. Nearly 90% had some element of psychosocial or spiritual need, particularly spiritual and psychological needs. And actually, since our findings, there's been a big report into palliative care across settings in the UK from HSIB, the government reporting agency, who's demonstrated that this is a pattern that we see across palliative care in the UK. An end-of-life care plan was present for 60% of our patients, and what we see is that since the demise of the Liverpool care pathway, that standardized care pathway for patients who are dying in hospitals, hospital sites have developed their own very varied and very different end-of-life care plans, with no particular guidance on how to construct those. Intervention from specialist reviewer was another outcome that we were looking at, and we found that 40% of patients needed some form of, 50% of patients required an immediate intervention, with 40% of that being prescribing, 10%, so 1 in 10 requiring an immediate administration of a symptom-focused medication. 15% required some element of psychosocial or spiritual care, 10% required, 11% required some mouth care, and 11% required some element of engagement with the end-of-life care plan. We did some sort of deeper statistical analysis, and we found that if you were dying in a teaching hospital or a cancer hospital, you were more likely to have your needs met. So you conversely, you have more likely to have unmet need if you're in a local general hospital. Equally, we found that although end-of-life care plans didn't remove any unmet need, there was still significant unmet need, the presence of one did help significantly. So not having an end-of-life care plan meant that you were much more likely to have an unmet need. We did some modelling, which perhaps, I'd admit, perhaps we got a bit overexcited and did the modelling. The modelling has demonstrated the independent influence of the type of hospital, and it also demonstrated that there was an influence of increased specialist palliative care staffing, which is one of the findings that sparked the most debate in terms of what the narrative around that is, influencing the need for intervention. But importantly, within that model, when we included the use of presence of an end-of-life care plan, the specialist palliative care staffing no longer influenced the need to intervene. So whether or not the end-of-life care plan replaces that specialist knowledge in that model is one way of looking at it. Another way is that perhaps hospitals with higher complexity have higher levels of medical staffing and therefore have higher level of need. But it's an interesting one that we can't explain away with our data. The important negatives, we didn't demonstrate any significant relationship with the type of ward, the diagnosis, the gender of the patient, and the staffing with CNSs, or whether or not they developed a 7-day service. We've got really, really significant limitations. And so I have to remind myself when I talk about how proud I am about this study, that actually this is a really flawed thing, and it's a very convenient thing to do, and that's why we've done it. But actually we're not pretending that we've answered all the questions here. So I know that we know from research conducted by one of our colleagues on the paper, Nicola White, that if you are a doctor versus a nurse versus a healthcare assistant, which is one of sort of the nursing assistants on the ward, or from a different background, the way that you identify, your ability to identify those that are dying is different. Some will be better, some will be worse. And so where we're going to the wards and we're asking who is dying on your ward, we're asking the nursing staff or the doctors. We didn't differentiate between who we asked in this study. We also didn't differentiate between whether or not it was a medic or a nurse from the specialist palliative care team who was going to do the review. And actually some may suggest, although I don't think I've seen this in research, that a doctor is more likely to respond by prescribing, and a nurse is more likely to respond by providing some other element of care. And so there may be some confounding in that we just didn't account for. We didn't account for those that were known to the specialist in palliative care, and that's probably the thing that I think we probably should have done. I think that would have given us a really nice comparison. It would have given us a nice standard to compare against. And the reason for that was that we didn't want to make it too much work. I certainly think it's something that we're considering doing in the next round, in the next iterations. And we didn't account for the actual mortality. And so had we somehow managed to capture the data of actually, when you went to the ward and you were told that those 3 patients were dying, there may have been another 5 patients who were dying that they didn't identify. And so the hope would have been that if we were able to capture actual mortality, we might be able to account for some of that failure of recognition. But understandably, that's actually a very difficult thing to do when you think about the complexities of mapping patient journeys through hospital. And I'm sure I'm speaking to the converted here. What does dying actually mean? I think just the key findings, just to summarize before I come to the panel I'm going to offer some questions to you as well as Scott, waiting for the questions back. But we found that there was nearly universal unmet need. We found that more than half of the patients we identified required some form of intervention. So you can sort of infer from that at least for those 57% of patients, they would have benefited from some guidance from the specialist palliative care team that wasn't being sought by the team that was managing them. The end-of-life care plans have a significant impact. So I forgot to mention that the negative predictive value of end-of-life care plans on your needs being met was around 0.98. So if you don't have an end-of-life care plan, your needs will not be met, is essentially what that's saying. Not that they account for all of your needs, but it's almost impossible to have your needs met without an end-of-life care plan. But I think one of the findings that I think it's difficult to capture in the more researchy way, but the narrative that you build is that we're looking at the problem of caring for people who are dying in a different way. And by doing so, we've opened the window, and now we can see that actually retrospective case note review is not sufficient to actually say what the quality of care that these people are receiving are. We're identifying needs that retrospective audit has never picked up. We've identified much more significant symptom burden, holistic need. We've demonstrated that there are deficiencies in care that you can't pick up when you're just looking back on what was given. So I think we're opening the door into maybe questioning what is valid when we're evaluating end-of-life care. And I don't think that this answers all of the questions that we would want to answer, but I certainly think it answers some of the questions, and perhaps some of the questions that we weren't even aware of before we started the study. The questions for me that I think about when I think about the next steps are what goes into an end-of-life care plan. And so when I say that, I mean that if there's such a lot of variation, but they do demonstrate an impact on someone's needs being met and whether or not a specialist reviewer needs to intervene, then there must be something in there that's powerful. And so one of the next steps in our work is we're working now with NHS benchmarking to develop this on an even bigger scale, and then try and map against elements of an end-of-life care plan so that we can maybe demonstrate the power of each element and then actually give statistical significance to the bits that make a difference to our patients. So that's sort of a next step for me. I'm concerned that we only had 6 patients in our 284 that were from non-white backgrounds, and only 6 others that didn't have their ethnicity identified. And I know from other studies, so papers that we produced during COVID, we demonstrated that patients who were non-white were much less likely to be referred early for palliative care. I don't know of the literature that says around recognition of dying, but one can infer that there is a reticence to engage with that topic from the specialist's point of view, and perhaps from the patient's point of view as well. But I do think that what we've got when we're demonstrating that this real dearth of patients from these other backgrounds in our data is that we need to look much more closely about how we recognize dying, how we identify those that are dying, so that we can then meet their needs, meet them where they are, rather than ignoring them or removing them from studies. As I say, how do we account for the fact that we're very bad as doctors and nurses, we're very bad at recognizing dying in general, but particularly if we're not specialists, maybe we're even worse. And whether or not we move into other settings. So we've had requests to try and use this methodology, looking at care home sector patients, or looking into the community, or looking and very reasonable questions, asking us why we're not looking at places like the emergency department or intensive care. And the reason is logistics. The reason is the ability to make changes, because when you go to the intensive care unit in the UK, often they operate a closed unit policy where you're not allowed to make interventions without consent from the supervising physician. And in the emergency department, things are so chaotic in the UK. I'm not sure how things are around the world, but our emergency departments are not places to try and do this sort of work, sadly. But that's, I think, where I'm going to leave you. I obviously want to say thank you to Juan and the team for organising today, but also to all the panelists, and I'm really excited to hear your thoughts. But the working group without whom I would never have been able to push this work through. Georgina Buller, and she would hate me even mentioning her name, but I mention her every time I talk about this work. She's the administrator at the APM, and she's the one person that made everything work. She coordinated all the sites, and it was just, without her, it wouldn't have happened. And just every member of staff who contributed, and every patient and their relatives that contributed. 284 patients on that day in May of last year had their care altered by this study, and hopefully for the better. And I'm very, very thankful for their engagement with it. So with that, I think I'm at about 15 minutes. So I'm going to just stop sharing my slides and we'll come to the panel.
Thank you, Simon. Well, first of all, congratulations. Without a doubt, I think that this is a very outbreaking milestone study. So we that because of that is precisely because we made this to have the opportunity to talk a little bit about the results and how this may change our understanding about primary palliative care, because as we all know, is something that we are all for, but we understand there are some complexities that we have to we need to dive in. So I'm going to I want to hear you all, but I do not know how to start. So if somebody wants to raise his hand and begin the conversation, but before we do that, I would just want to say hi also to Miguel Sanchez. He's the director of the Colombian Palliative Care Observatory, and Luisa Rodriguez, who is our president of the Colombian Association. So let me know who wants to start, and if you don't mind, then I'll go ahead and give the word.
I'm always happy to. I'm sorry. And to Miguel and Luisa, you should be so proud of Dr. Correa and everything that he adds to this incredible community, bringing people from around the world together. It is such an honor to know him in Columbia, South Carolina, which I feel like we should have some sisterness. Simon, what an incredible study! What an incredible look at these unmet needs. One question that I had is, as a palliative care doctor in the States, I wonder if you were to walk into the rooms of the patients on my service, even those who have a plan in place, an end-of-life care plan, or even are on hospice, if you were to catch them at the right moment, what percentage of those do you think would have symptoms that are requiring intervention?
I think you're very right to raise that point, and it's a point that I'm familiar with. I think you're right that there will be patients for whom there is a plan in place and it's appropriate, and there will be highs and lows through the day. And that's why we try to make up for that by capturing not just the unmet need, but whether or not an intervention was needed. I think you're right to point out that, yes, my patients in the hospice, my patients on the wards very regularly need extra medication. That's sort of the point of them being there. If they didn't, they could be at home. But I think that even that 10% where patients required intervention immediately, there was another 10% where immediate prescribing changes were needed to be made. There were other patients who required other interventions beyond the administration of medicine. So you're right, and I think in future iterations, when we include those that are known to specialists in palliative care, we'll have that comparator. So we'll be able to demonstrate much more clearly what the differential is. But I do think that there is a real difference between the care of those received, whose care is guided, by generalists versus specialists. And I do think there is something that we're capturing here that is real. But I agree, though it's definitely confounding there as well.
I'm certainly not saying that that's not real. Anytime that I walk into a room of a patient that I'm meeting for the first time, I think it's much more common that I'll see an unmet need compared to someone that I'm already following. Thank you for that point.
Thank you for the question. I also think there's actually just one extra point that I'd make just before we move on. We in the UK have a really weird funding structure to our palliative care services, in that about 20% on average is funded by the NHS and the rest is funded by charities. There's lots of variation regionally. And in hospital, it tends to be NHS funded, but you're never 100% sure. I work with a team at UCLH, which is a big, shiny cancer hospital in the centre of London that's very rich and has lots of money and can afford to do quite a lot of interesting things. And the team that I work with, the end-of-life care team there, has recently secured funding for 7 days a week visiting service from clinical nurse specialists, where every single patient, regardless of the perceived complexity, every single patient who is recognised as dying or at risk of dying is reviewed every single day by those specialists. And we demonstrate by using standardised collection tools and standardised review tools that actually their care is significantly better as a result, because of that continued look from that specialist with that holistic background. And so whilst that's very much the ivory tower, and I can't imagine even the best funded hospitals elsewhere have similar services to that extent, where they're 7 days a week with those specialist nurses who are independent and often are prescribers themselves. I think what we're demonstrating there is that there is a way to get around this. We can sort of find a way of supporting the generalists a little bit better. But I'll come to the next question, if that's okay.
I'm sure that we want to hear a little bit more about that. But before we do, I'll give the word to Sheila Payne. Go ahead, Sheila.
Thank you. So congratulations, Simon. An excellent study, even though you rightly point out some limitations of the UK that tends to score well on league tables of palliative and end-of-life care, but clearly getting it quite badly wrong in some areas. So I'm assuming that most of your data, or virtually all of it, was collected in NHS, so publicly funded hospitals. There are 3 points I'd like to make, which perhaps broadens it a little bit beyond the UK. So you may be aware of Mary Niven's work from the Republic of Ireland, and she looked in her PhD work particularly about non-specialist palliative care providers in Ireland. And that may be something that is useful for you to look at and some of the work that they're doing there. You mentioned, so that's my point number one. Point number two is you mentioned that you were thinking of repeating this in care homes, nursing homes, or sometimes they're called long-term care facilities. And there was a really large European Commission funded study called PACE, which is Palliative Care for Older People. And it involved 7 European countries in a trial. But before the trial, what we did was a kind of audit rather similar to yours, where we looked at samples of nursing homes or care homes across a number of European countries, in this case 6 European countries, but with large samples. And the data are published. They're incredibly similar to yours. And mostly we sent an evaluator into each of the care homes. So this was not done just on case note review or anything. So it was going in, collecting data from different sources, but actually physically going into the nursing homes. And interestingly, there were kind of 2 groups from the managers' perspectives. They either said nobody in the care home was dying because all of them were not at that stage moribund, or they said everybody's dying because all older people were considered to be in the process of long-term dying. Now, the average life expectancy in the UK in a care home is around about 2 years. So there was a real divergence in views, but the notion of recognizing dying was hugely problematic. And I think you've highlighted something really important there. And certainly in our data from that study, we showed that actually they were very, very poor at recognizing dying. There was, after an intervention, because we followed that up with a cluster randomized control trial, and we were able to demonstrate after a very intensive 6-month intervention that there was no evidence of benefit for the patients on their data, but there was a benefit in terms of knowledge from care home staff. So we increased the awareness and knowledge of end-of-life care in staff from that. My final sort of point, and you may know about this research, the King's College in London, very large hospital and an important university, in their Department of Nursing, they have been for a number of years looking at researching care not done. So when hospitals get very busy and there is pressure on nursing staff, which there is in many countries, and that has got worse through the pandemic or through austerity times when there's a lot of cuts in staffing. Things are not done, like mouth care, and you really demonstrate that. And one of the interesting things when they looked at very large data sets from UK NHS hospitals is that they found that there was less care not done in terms of having highly qualified nurses. So if you had degree level or well-qualified senior nurses, compared to just putting in lots of very cheap but unqualified nursing assistants or care assistants. So just people on the ground do not make the difference. It's the level of education and training that appears to make the difference. Now, this study wasn't particularly about end-of-life care, but since about 1/3 of people we know from David Clark's work in NHS hospitals are approaching the end of life, it may be something that is relevant. So those are the points, and you might want to come back and reflect on those, but thank you for your work.
Oh, gosh, thank you so much. There's so much to think about, and I'm picking that. And I've made a note of some of the names that you spoke of, because I wasn't aware of Mary Niven's work in Northern Ireland, so I'll certainly follow up with that. I think the points you speak to about the recognition of dying in the care sector are very familiar, and I think you're right. And actually, the points that those care managers and nurses were making, actually, what is dying? You know, is it the sort of the slow dying, or is it the last days, or what classifies that? I think they're very valid, and I think that the conversation we need to have is probably a little bit more nuanced than just the word dying. It's probably, as you sort of allude to, it's actually, are they dying in the next 3 days? Are they dying in the next weeks? Are they dying in the next months? Are they dying in the next years? And each group is dying, but perhaps requires a slightly different response. And certainly when we're looking at moving this work into the care sector, we'll have to adapt it, because we'll probably want to capture those that are in, say, the last year of their life and how their care is shaped, rather than just simply those that are in the last hours to days. So I think that's a really, really wonderful point, and thank you for making it. I think that there's so much interesting stuff happening at King's. It's an institution, it's a hospital, and it's a university that's doing so much interesting work. They have the Cicely Saunders Institute of Palliative Care Research there, which is probably one of the bigger in the UK. And I was sort of peripherally aware of the Care Not Done side of things that they're doing, but actually we've had follow-on conversations after SEEcare with Kathleen Sleeman, who's one of the professors there within the Cicely Saunders Institute, and she's recently been awarded a pot of money to do end-of-life care policy research, and there's a real overlap in our interests here. And actually, knowing that work around work not done is coming through King's anyway, it would make sense that where we're exploring that relationship, we try and maybe link up there, because, as you say, mouth care is care that every single patient should receive. Mouth care is most often the thing that is poor in patients that are dying in hospitals and care settings. And so I think it's one of the things that we could very easily look at as work not done, but in an end-of-life care context. So thank you again for the link there, and for the broader perspective on the world of palliative care. I'm very grateful for it. Thank you.
Simon, just a quick note. Catherine made the impossible and the impossible to be here. She didn't make it, but she asked me to pass her the recording afterwards. So I'll definitely do so. Okay. Thank you, Sheila, for your remarks. Without a doubt, the UK has been a leader in the quality of death index and dying in the different versions that have been published. And well, I have a comment with that regarding that. But before that, I want to give the word to Rebecca. Please.
Yes, I agree, Simon. This study brings up so many points that need to be addressed, and you don't even know where to start, really. I recently have been working on some educational products for diagnosing dying, and actually have started to write a nursing diagnosis or a syndrome, and I think that is the crux of what we need. People need to know what they're looking at, and so many of us don't. And the other thing I wanted to talk about was the ICU, the complexity of the ICU, and it is equally true here. And I did a similar QI project where we had automatic triggers, and we went into the ICU, and it's a little different as far as the welcoming committee. They're not quite as obvious in the ICU, but they the thing is that we found that the doctors, the physicians who allowed us to see their patients, their outcomes were off the charts better than those who refused treatment. The ones that refused our interventions, their patients did horribly, and they lived much longer, but it was a prolonged and agonizing death. The question that I have, though, is I'm really interested in your end-of-life care plan, because we have what we call advanced directives here in the U.S., and we also have something called the Physician's Orders for Life-Sustaining Treatment, advanced directives in the United States are typically prepared by attorneys. The perfect people to talk about end-of-life issues and symptoms. But so I'm wondering, can you talk a little bit about what is included in that and how you could make it more standardized, or please?
Absolutely. No, thank you so much for your point. I really recognize your the point you're making around the intensive care unit. I've recently been engaged with some sort of longer form quality improvement with the intensive care units across UCLH. And I can say that what we're talking about, rather than it being a straightforward intervention where, you know, on some of the medical wards, it might be a couple of education sessions and a new pro forma or a new set of observations or a new policy. This is a much longer culture focused intervention where we're trying to open those conversations and understand the barriers that people have. Diagnosing dying is really difficult, and I imagine in the intensive care unit for those physicians and those specialists, it must be impossible, because every single patient that goes to the intensive care unit is sick enough to die. And so recognizing those that will and those that won't is, I think, immensely challenging, and challenging not just on a professional level, but on a personal level, because of the responsibility that one feels for patients that you put through this ordeal of going to the intensive care unit. So I really recognize that. And I'm interested in the sort of the syndrome of dying that you talk about. I think historically we've done, I mean, there's a professor at UCL called Paddy Stone, whose career's work has been trying to identify how we prognosticate, how we come up with the figures and whether or not we can improve them. And he's developed models that are linking in specialist knowledge with biochemical markers, and has never really found the answer, never really found success. There may be something with the inclusion of AI technologies that may make us slightly better at that, but I think we're still a long way off, and I think it would be really exciting to be able to properly recognize dying. With regards to the end-of-life care plans in the UK, so the Liverpool Care Pathway was sort of the archetype that went through elements of holistic care that one might need to consider for people who are dying. And so it may be that, you know, we stop measuring somebody's blood pressure, but we make sure that we're doing routine observations of their pain. It may be that we stop their intravenous feeding, their intravenous nutrition, but we focus on making sure that their mouth is moist and that their needs are met in other ways. The principles that underpin most of the care plans in the UK now are those that were outlined in the Leadership Alliance for the Dying Persons report, One Chance to Get It Right. And that was in response to all of the controversy around the Liverpool Care Pathway. And they're broad principles. So they're not specific tasks that one must do. But the idea is that first you need to recognize that someone is dying. Once recognized, you need to communicate with those that are involved in the person's care. So that would be all of your staff, but also their relatives. You need to involve the right people. So that might be their next of kin, their loved ones, as well as maybe members of their community, their faith community, broader in their life, as well as people in the hospital. You need to actively offer and provide support to those that are important to the person. And then you need to plan and do. And the plan and do bit is where we write down things like our plan for someone's hydration and nutrition, our plan for escalation should someone's symptoms worsen, or what spiritual support they might require. So that's the sort of the architecture of most of the end-of-life care plans across the UK. But how they're operationalized is vastly different, hospital to hospital, trust to trust. Some teams will have a one-off form that you fill in after a conversation, and then care is sort of implicitly guided, but there is no further sort of interaction with planning for end-of-life care. Some will have daily review templates where people will evaluate the care they're providing against the plan and say, am I still hitting this person's priorities? Am I still meeting their goals? And others will have other variations. And so part of the research that I'd be really interested to do is taking all of those different variations in how we do end-of-life care and planning in hospitals. And I'm trying to unpick which bits actually have the influence on the patient and their loved one's experience. And I think it would be easily done. I think probably what we would find, and I think this is, I don't think I'm going to be speaking to a contentious point here. I don't think it's the plan that makes the difference, but it's what the plan captures. And if you have a plan that can capture or encourage people to have conversations in a certain way that is supportive and compassionate, if you have a plan that can encourage people to be proactive when looking for symptoms rather than reactive, then perhaps that plan will have power beyond what's written on the screen. But I think we do need to do a little bit more investigation, given that these are things that are in place in all hospitals across the UK, that we probably should know which bits make the difference.
You know, I think that part of the issue is true, full, informed consent. Because so many people are accepting things and they don't even know what it's going to look like after they do it. So I'll leave it at that. Thank you so much.
Agree. I completely agree. Thank you for your point.
Ben, I saw that you raised your hand, but I'm going to give I'm going to give the word to Mary. I can see that you. Please go ahead.
I can't find my raise my hand button, so I'm physically raising my hand. I was just curious about the end-of-life care plans. You know, the study I did really looked at the interactions between the specialist palliative care teams in the hospital and generalist teams out in the community. So are those end-of-life care plans only dealt with or created in the hospital, or is that something that primary care teams would also help develop prior to a hospitalization?
So the care plans generally pertain to the direct care in the sort of here and now. So it talks about, it talks about whether or not we're going to give subcutaneous fluids or intravenous fluids or antibiotics if we see things, or pain, etc. So the care plans that we talk about in our study are hospital-focused care plans. However, I'm aware, and I've worked within teams where, so there are some areas of our community practice where they don't use care plans, and there are some areas where they do. And I've interacted with them, and they're pretty similar. The only difference is they have to say where the drugs are, because it's not maybe always as obvious as it is on a hospital ward. But I think that's we do have care plans that are in the community. They are separate, and within London, and there is an inequity in how we provide palliative care in the UK, and London gets a lot of the incentives first. So in London, we now have a digital platform through which we can communicate with our community partners, ambulance drivers, GPs, and primary care physicians, as well as oncologists and whoever else is involved in their care. We now have that platform. It's called the Universal Care Plan, and they prioritize end-of-life care planning above all else. And so the first module that's been live now for about a year is around end-of-life care planning. The next modules will be around other illnesses like COPD, chronic obstructive pulmonary disease, or heart failure or kidney disease, to try and plan in advance. The lovely thing about that digital platform as well is that it's accessible. In the next month, it's going to be accessible by patients on their app, on the phone, on their NHS app through their phone. So they'll be able to engage with it and request changes in the same way as their physicians. So I think that really speaks to informed consent, as Rebecca was alluding to, but it also speaks to that sort of boundaries of care, because I think often the biggest deficits is, as I'm sure I'm speaking to, I'm sorry, the phrase in English is teaching grandmother to suck eggs, which I don't know if that translates very well, but it means you're the expert, and I don't know why I'm telling you about this. But the biggest deficiencies we see are when transitions in care happen and information is lost. and specialism is lost. So I really recognize again, but the situation in the UK, there are care plans in the community. They're not necessarily continuous with those that are in the acute sector, but we are trying to work through that.
We could go down a rabbit hole here, so I don't just wanted to make a comment and then we can move. But I'm interested in the idea that an individual could go on and change their care plan independently without potentially conversation with their care team, and what that would look like. And I think different health systems across the world, that would mean different things. Because maybe some things are not available to everyone, but we have a lot of conversation here in the States, in my team especially, or in particular, about the reasons people choose to have aggressive treatments done when maybe they don't make a lot of sense, and that fear that people are holding, and just doing anything to avoid dying. So just that would be another interesting conversation.
I'll come back to that very quickly, just to provide clarity. I think I maybe was a bit sweeping in my statement. So patients will be able to access and change certain elements of their care plan. And so things such as personal priorities, personal choices. So things like we are forever governed by a metric, which is somebody's preferred place of care and preferred place of death. It's one of the things that was very easily measurable, and as such has found itself as a key performance indicator for a lot of services. Although actually in real life, it doesn't matter that much to people. But things like that, they'd be able to alter. They'd be able to request conversations to look at other elements of the care plan, but they wouldn't be directly changing things such as their morphine dose, for example, or whether or not necessarily be conveyed back to hospital in the positive way. I think so. So there are some safeguards around it, and I recognise the concern that you expressed there. It's very fair.
I want to make a short recommendation. Sorry, Mary, were you about to say something else?
No, that's okay. Go ahead.
I want to make a short recommendation, something that Sheila brought up in the chat. Currently, there's an European Commission funded study called Pulse Cycles. She put the link in the chat if you want to double check on that, because it's regarding what we have talked so far. Finally, we're about to close. 8 minutes to go. Dr. Marta, please go ahead.
Thank you, Juan, and thank you to all of you. We want to say, as Ben said at the beginning, we're very proud of Juan. So of all the work he has been doing, and to try to integrate us with all the knowledge that you have. So it's great to be here, and I also am representing all the people from Colombia that are here, the observatory, the association, and a lot of the residents of the palliative care program. So thank you very, very much. We have a lot of differences. We are being during the time that you have been speaking, Simon. We know that we have a lot of differences, and as Sheila said, this care not done for us is not only at the end of life, but all through the whole time of the process. So we have a lot of different things from the ones you're having, and sometimes we're not so focused only in the end of life, because we have to focus in a lot of things before that we haven't solved really in the country right now. But there are two things I was thinking of what Mary said, and it's a little thing and a big question also. The thing is, if there's any difference that you have realized, Simon, with these end of life plans, depending if they were done before or they were done later, to the need of the specialist. If the time where the end of life plan was done is made any type of difference in the need of in the needs not met and the need of the specialist. That's one. And the other one that for us, and I think it can be for Simon and for Sheila and for all of us, or for all of you, is how you think it will be this integration of these specialists in palliative care with the primary care to try to meet these not met needs, because for us it's a very, very important thing to know how you integrate, how you feel this integration that you're trying to show in the Simon paper, but Sheila has shown us, and all of you have talked, how this integration between these specialists and this primary care to try to meet the needs that they have can be done, and these papers and these investigations are showing us this. Thank you very much, Juan. Thank you, and thank you all of you for being with us.
Oh, thank you, and thank you so much for that question. I think that's you made two very, very important points there. I think because of the variation in design and implementation of the end-of-life care plans. So, like I say, some of them will exist as a one-off event where you write the end-of-life care plan. Some of them will be reviewed every single day formally. Some will be reviewed every single day less formally. It's difficult to pick out when we say the time difference from the end-of-life care plan, although I completely see the point that you make, because people's needs change over time. And so if you're referring back to a care plan that was created 2 weeks ago, it's very likely that that won't meet the needs that they have today. But that's not a part of the study that we've done. And certainly the practice that I've experienced sort of on a more anecdotal level, I think I can see the deficit that you point out there. In terms of the integration with the non-specialists and the specialists in palliative care and how we better meet these unmet needs, I presented this at a conference a few months ago, and people were drawing me on that point. And I'm very careful, because this is a service evaluation. This is not an answer. This is not going to give us answers on how we can do things better. So we can show what the pattern was, but we can't show what the pattern should be, could be, or would be. What we can say is that teaching hospitals and cancer centres, where the average staffing ratio in terms of nursing staffing and medical staffing is higher, so there'll be more doctors and nurses per patient, that the level of unmet need was lower. So that would imply that more staff on the wards means that your care will be better. And we showed that the presence of an end-of-life care plan, in whatever form, improved your care, but it didn't completely improve your care to the point you didn't have unmet needs. And we don't really understand what elements of the end-of-life care plan would do that. And so research is needed into that. I think on a personal level, like I say, I've worked with this fantastic service where there's 7-day-a-week visiting for patients who are dying. I've worked in hospitals where you have a consultant who comes for 1 morning a week and a CNS who's there for 3 afternoons in palliative care, and the rest of the time they have no palliative care support. So the offer in the UK is so varied that we can't say to the hospital where there's 1 consultant in an afternoon a week that he has to then find a service where they can have 7-day visiting for all patients who are dying. And we can't say to the hospital where they have that service that they need to sort of dumb things down to the level where that person is. We need to find the elements of care that improve, the elements of integration that improve patient experience. And so further research, I know that's the cop-out that anyone who does research says, but further research is needed. We need to look at these relationships. We need to understand what it is that makes a difference for people. And probably that information then needs to be used in places across the world. What works in the UK with our very different system with the NHS, which is a real anomaly in healthcare systems across the world, may not work in America or Colombia or Canada or wherever else, we're looking at systems. But we need to think, what are the core elements, and how can we then reflect on our own practice and investigate our own practice, keeping the patient at the very, very center of all of it. I'm sorry, that was a very political answer. I didn't really answer your question, but I don't think that there is an easy answer, sadly.
I think that at the end we have more questions than answers, but that's the idea. We all have to do more research about this. Actually, we were checking because we're right now in Colombia, we're implementing the National Care Plan, and our bet is on primary palliative care. But because of your results, we had to stop and question ourselves, because how we can bet on that if we're not sure if it's going to work. And I think that in a very broad conclusion of what we talk is trying to improve education, right? And that's mainly what we have to focus right now. So I know. Go ahead.
I just want to say one thing, which is, well, and the other thing to take with this approach is you can roll out your care plan, but so long as you keep questioning and you keep asking, are we doing the right thing? Are our patients getting good care as a result? Then you can shape things so that you'll be miles ahead of us in the UK. So I think it's that ongoing research, that ongoing questioning, that ongoing evaluation, where you look at the problem from as many different perspectives as you can. And so SEEcare is one perspective, but you've got the patient's experience, the staff experience, and you keep evaluating their experience, and eventually we'll get there. Eventually we will.
Correct. I agree. I know that you have, Simon, a very long ride, so I'm not going to take more of your time. Thank you very much to all of you for being here. I want to also give credit to Laura Cuellar and Nidia Mantilla, who were my helpers in coordinating all these sessions. Thank you, Rebecca, Ben, Sheila, Mary, Marta, Luisa, everyone for being here. This is going to be a bi-monthly meeting. We're going to bring the top researchers on palliative care to discuss their findings, and we'll continue to invite all of you so we can have an hour to talk and to learn.